Good afternoon. We meet up again. My name is Dr. Wong Teck Wee. I'm a consultant cardiologist. And for the last few months, we have been running a series of interesting conditions. And today I have a very important person, and he can explain some of the conditions that we see in our clinics, especially for general practitioners. Even for a cardiologist, sometimes my work is very similar to general practitioner. Some patient who has constipation also, they come and ask us. So with that, I want to introduce Dr. Charng Jeng. He's a consultant neurosurgeon and an interventional pain specialist at Sunway Medical Center. He's also the founding and current president of the Malaysia Society of Endoscopic Spine Surgery. And he's also the past president of the Malaysia Society of Interventional Pain Practitioner. Before coming to Sunway, he was an associate professor in hospital UKM. So with that introduction, I want to invite him to talk about comforting chronic pain, exploring holistic approach for the pain management. So with that, I want to invite Dr. To to speak on this topic. Thank you, Dr. To.
Thank you, Dr. Wong, for kind introduction. Now I share my screen. Okay, today our topic is about pain, how to comfort the pain, and we look for this holistic approach for pain management. Introduction is mainly talking about how severe and how high is the prevalence of chronic pain. So chronic pain is among 11 to 40% prevalence rate in US. Is considered as one of the most important health issue and involve a lot of money in treating them. So identify the patient correct pain issue is very important because we don't want to misdiagnose and make the patient suffer. Why misdiagnosed pain can make patients suffer more? We have to go slowly one by one. So definition of pain. Pain is an unpleasant sensory and emotional experience associated with or resembling. Now the word resembling is coined in 2020. It's a new word that associated with actual or potential tissue damage. So it may be a tissue damage, may not be a obvious tissue damage, but chronic pain is a disease with its own pathology, symptoms and signs based on pathophysiology changes brought by pain itself. So now we have to understand that acute pain and chronic pain is two different identity, and chronic pain now is considered as a disease. No more is a symptoms. So acute pain is different from chronic pain. Acute pain is more of physiology, and most of the time it's nociceptive because it's a physiology to alert the patient there's some inflammation, this and that. And chronic pain is a pathology. A lot of times it's neuropathic or mixed. So acute pain is a symptoms and chronic pain is a disease. So now type of pain. Before this, we only learned nociceptive pain and neuropathic pain. And now we have a new pain we call nociplastic pain. Nociceptive pain is associated with ongoing input from real or threatened tissue injury. And neuropathic pain is mainly the disease of injury or injury affecting the peripheral or central nervous system. What is nociplastic pain? Nociplastic pain is pain arising from the altered function pain-related sensory pathway on the peripheral and central nervous system causing increasing sensitivity. That means patient having this pain processing pathway which is actually altered or dysfunction and may process pain more severe than normal people. So the most important thing we need to differentiate between neuropathic and nociceptive because the treatment is totally different. So the cause, we already know, the cause is of the injury to the nervous system, and nociceptive is more of tissue damage. So descriptors, how patient describe neuropathic pain? They're lancinating, shooting, electrical light feeling, stabbing, burning. Burning is very classical for the neuropathic pain. And also the itch, itchy. Some of us may experience some itchiness here and there, but there's nothing happened to the skin. It's actually a misfiring of our skin sensory nerve. So for nociceptive, it's more throbbing, aching, or pressure-like, or cramping-like of feeling. So sensory deficit is quite common for patients with neuropathic pain, but it's uncommon for the nociceptive pain. That means when you have a patient complain of pain over a numb area or lost sensory area, is most likely a neuropathic pain. Motor deficit, depending on the nerve injury, if a mixed nerve patient will develop a motor deficit. But in nociceptive pain, it's unlikely any motor weakness. However, patient may restrict their movement mainly because of the pain. Hypersensitivity, allodynia, and hyperesthesia. That means the painful area are very sensitive to touch. Even the cotton touch can cause a lot of pain. We call allodynia. Hyperesthesia is the painful sensation more than what a normal people can feel. So paroxysm. Paroxysm is because a patient having this neuropathic pain on and off, having an exacerbation and unpredictable. They come and go without the patient realizing it. But less for nociceptive pain because they are more predictable. We can see the inflammation worsening, the pain worsening. Autonomic sign. Autonomic sign is a sympathetic sign. You can have color changes like your Raynaud disease, like your complex regional pain syndrome, temperature changes, swelling or pseudomotor, sweating of the skin, but uncommon for nociceptive pain. So why chronic pain need to be treated? Why chronic pain need to pay attention? Patient otherwise normal from this cartoon. One day they develop a pain sensation, which is intense. Initially, patient was seeking for help. Of course, we doctors a lot of time seeing patient complain of pain, and pain is the most common complaint for patient come to seek consultation. Yet, I can say that is most neglected because until today, there's no instrument can measure pain. A lot of time we don't see sign of inflammation, means patient may be making up a story or maybe it's actually from their brain. And when the pain becomes intense and prolonged duration, this will cause the patient feel a little bit hopeless, helpless, lacking of sleep, stress, frustration. Is that all? No. Patient may develop severe depression, and sometimes they may have a suicidal intention. So this is what we have to treat pain, especially chronic pain, in a very careful way. So what the pain can affecting a person? Psychological means emotional disturbance. Social, he may affecting the relationship between the patient and the family, patient and the friends. So social may be get interrupted. Financial is the patient in chronic pain or in suffering in pain will continue seeking for answer. Many MRI, many times consultation, and yet sometimes they do few MRI in a month to find the answer. So how to have a holistic approach we call biopsychosocial. Take care of the biomedical area, psychological area, and sometimes we also need to pay attention to their social area. So in managing pain, the most important is to rule out red flag condition. Is the patient having some lesion that actually life-threatening or limb-threatening? So we need to rule out before we treat the pain per se. Yellow flag condition is very important to identify. Means the patient having some depression, some anxiety. All these things have to be addressed so that the pain can be managed holistically. So physiology and pathophysiology of pain, I will move very fast. We have to know what kind of nerve fiber carry what kind of sensation. This is important when we do some surgery to the nerve root. And this is, you can see that the more anterior part of the dorsal root having more of pain sensation fiber, posterior part of the nerve root more of proprioception. So this is a tract. This our tract is a tract that actually they cross in the same side up and down for a few segments before he crossed to the opposite side in the spinal thalamic tract. So this is another picture for spinal thalamic tract. They actually cross in the level of spinal cord level. And this is what we call nociplastic feature of pain. Nociplastic feature of pain is they combine peripheral and central sensitization, hyper-responsive to pain stimuli, and non-painful sensory stimuli. Your patient will associate with fatigue, sleep disturbance, cognitive disturbance, hypersensitivity to the environmental stimuli, anxiety, and depressed mood. Supraspinal mechanism, that means in the brain area. The brain area, a lot of area of the brain which is actually related to emotion will be affected. And also in the spinal level. The spinal level also increase the pain processing sensory level. and peripheral will cause some outsprouting of the nerve fiber and make it more of a pain sensation like allodynia and hyperesthesia. So this is the pain pathway. You can see the pain pathway, the pain track is not going to the sensory cortex per se. They are also going to the other part of the cortex that is actually affecting the cognitive and also emotion. This is another, we skip this. Okay, we skip this, already explained. This is what's the mechanism of neuropathic pain. I think you can go through after the talk. Okay, this is pain matrix. Pain matrix is actually a new term or maybe a concept. Pain are not situated in one area of the brain which called sensory cortex. It involved in many areas of the brain. You can see this picture on your left side. This is healthy patient with some sensory stimuli, but this is on the left side. On the right side is the patient in pain, chronic pain. You can see many areas are brightened up or lightened up. So this is very important. The pain fiber is not only going to sensory cortex, they're also going to few of the frontal lobe area, like cingulate gyrus in the yellow color, in the prefrontal cortex or in the anterior prefrontal cortex, and also the amygdala, and also hippocampus, insula. All these things is affecting the patient's emotion. When insula is stimulated, the patient will feel fear and catastrophizing. Go to anterior cingulate cortex will cause depression. Go to prefrontal cortex will cause focus issue. Amygdala will cause desire problem. So overview of pain management. Okay. The most important is still the history, because until today, we have no tools to actually confirm the patient having pain or not. We can actually simply tell you are fever. We can simply tell you are hypertension. We can simply tell you are diabetes, but we can't tell whether you have pain, your pain is fake or real. So the most important thing is a clinical history. I always tell the patient, your history is my diagnosis. It's not my investigation will confirm your diagnosis. So in the clinical history also need to involve the yellow flag condition, clinical examination to narrow down the pain generator. Pain generator means what is the pain producing tissue? Muscle, bone, skin, nerve. We can narrow down the pain generator, then we know which part of the patient is having the pain. Investigation, more or less, to rule out red flag condition. We don't want to miss a tumor in the spinal cord. We don't want to miss a tumor in the brain that we don't know this is actually the real cause of the pain. And ultimately, the diagnosis is only either by elicit the pain or by blocking the pain. Previously, we only have medical treatment. If the medical treatment fails, the patient will live in misery. So we have to look forward. Higher level of treatment means interventional pain, and of course, later neuromodulation and some ablative surgery. So previously, WHO analgesic ladder tell us what to do to increase the level of the analgesic medicine. But currently, we know that interventional pain can implement in between. No need to wait until fail all the medical treatment, because treatment is very important to start early to reduce the chronicity of the pain. So previously, we have all the cognitive behavior therapy, surgery, physiotherapy, medication. We're just missing a puzzle. This puzzle we call interventional pain procedure. So now come overview of pain management, biopsycho, social approach. We have a biomedical, psychological, and social. Biomedical is physical treatment, medical treatment, medicine, intervention, and of course some neurosurgery procedure. Psychological is cognitive behavior therapy. Usually the psychologists will help. They will actually give some calming therapy, distraction therapy, relaxation therapy for the patient. Of course, social part also we have to taking care. So in the medical therapy, we have nociceptive and neuropathic. This is very important understanding. We have to identify whether the patient is having a nociceptive pain or neuropathic pain. Why? Because the medicine is totally different. In nociceptive pain, we can give acetaminophen, PCN, and anti-inflammation like your NSAIDs and COX-2. And neuropathic pain are not responding to the nociceptive pain medication. A lot of times I see patients on nociceptive pain medication, which is not helpful at all. So what are the medicine for the neuropathic pain? Anti-epileptic like gabapentin, Lyrica, carbamazepine, antidepressant like amitriptyline, duloxetine, And sometimes we need to give opioid. Opioid is more of nociceptive pain, but also help in the neuropathic pain. But I believe in the general practitioner clinic, usually we can give the tramadol or Atracet. Atracet is combination of Panadol and also tramadol, and less side effect of the tramadol is to the patient. So now come to the other management, like your interventional pain. Surface marking, ultrasound guided, and fluoroscopy guided. I believe many of the general practitioners start doing some pain intervention procedure in their clinic. Some of them using a surface marking, some of them using an ultrasound. Fluoroscopy guided are not popular among GP in Malaysia. So what are the surgical procedures? Just for awareness, we have the spinal surgery, which is actually vertebroplasty, kyphoplasty, endoscopic, and minimal invasive surgery. Functional neurosurgery like microvascular decompression for trigeminal neuralgia. Radio surgery, we can have gamma knife. And then neuromodulation, we have drug, intrathecal, intraventricular, and also electrical stimulation like your spinal cord stimulation, occipital nerve stimulation, peripheral nerve stimulation, deep brain stimulation. Lesioning therapy surgery is just like to cut off the pain pathway in the level of nerve root, in the level of spinal cord, in the level of brainstem, and also brain. So myofascial pain syndrome is a very common pain syndrome we see daily in our clinic. There's approximately 47% of the chronic pain is musculoskeletal in origin. They can happen in the patient with a whiplash injury, fibromyalgia, myofascial pain syndrome, tension headache, and low back pain. So we see a lot of this kind of patient in our clinic and can be easily treated with some simple intervention procedure. So myofascial pain is characterized by the presence of painful localized region of the muscle and or myofascial trigger point. And this location is actually in a certain area of the a group of skeletal muscle being tender to palpation and become spasm. So I think it's too much of writing regarding the diagnosis of the myofascial trigger point. But once you go further, you can tell it's actually very commonly seen. So what is the question we normally ask, is there a regional pain, myofascial pain with trigger point? That means a particular group of muscle becomes spasm. Is there any other pain generator or any other structure that can cause pain? Is there any other reason for the pain? Inflammation, psychological, metabolic. Metabolic, like your hypothyroidism patient can have generalized body ache. Then whether this is actually a regional pain or maybe a widespread pain like fibromyalgia. So this is the example of myofascial pain. This commonly seen currently in our lifestyle, is sitting in front of a computer or looking at your handphone, a lot of trapezius muscle or neck muscle spasm. This muscle spasm can radiate the pain to the head. And the patient may complain the pain at the temporal site, near to the eye there. And this is actually a tension headache. Tension headache a lot of time because of the tension of the surrounding neck and shoulder muscle. By identify the trigger point, you can give some injection. Normally, you can give lignocaine. Somebody even add in some steroid. But study have done that the Botox and the lignocaine doesn't seem to be a lot difference in the outcome. So like this one with the sternocleidomastoid pain, patient may have some forehead pain around the eye and also the cheek pain depending on the deep division or sternal division or clavicular division of the sternocleidomastoid. So in the deeper muscle of the neck can give you a vertex pain. Like in the lumbar region, in the quadratus lumborum, muscle spasm can give you the pain at the buttock, thigh, and near to the groin as well. So you see, the trigger point injection is you feel the muscle. There are so many muscles that quite commonly in certain part of the muscle is easily in spasm. And this, you can feel it like a nodule. When you feel the nodule, then you can poke the needle into the nodule and give some medicine. We can give lignocaine to loosen the nodule. But to loosen the nodule is not the management long-term. The patient should send for physiotherapy to prevent the development of the spasm again. So what is nerve entrapment syndrome is another condition again. So the most important thing is we need to differentiate between dermatome and cutaneous nerve. Dermatome is nerve root area supplying the skin area. Cutaneous nerve is a nerve supplying the certain area of the skin. So you see this picture showing there's the multiple tone of color is dermatome. And the one with the nerve fiber is actually a cutaneous nerve supply. So how to know dermatome, which level, at which part of the body? Very simple that we remember nipple is T4, ZV sternum is T8, and umbilical solid is T10. I didn't change the T10, and just above the pubic symphysis is T12. By knowing these few spots, then you roughly can tell which nerve root is involved. This is dermatome. So entrapment and neuropathy is actually entrapment of the cutaneous nerve. Cutaneous nerve is quite common, like carpal tunnel syndrome is one of the entrapment neuropathy. Morton metatarsalgia is actually at the sole there. Ulnar neuropathy, neuralgia parasitica is actually an entrapment of the lateral cutaneous nerve of the thigh, commonly seen and misdiagnosed as lumbar pathology. Radial nerve neuropathy. This is the pathophysiology of the entrapment. The entrapment, if you don't treat them early, they may cause ischemia to the nerve, ultimately fibrosis and nerve loss of function. The skin area becomes numb, but pain persists. So occipital neuralgia is a nerve entrapment of the greater and lesser occipital nerve. Usually happen at the back posture, especially people who use computer with the head move forward and then actually cause a lot of straining at the deep muscle of the upper neck. And this can cause impingement of the greater and lesser occipital nerve. So this is greater occipital nerve. You can do a block in the greater occipital nerve by putting your finger one at the mastoid process, the other one as an external occipital protuberance. One third is a surface marking for the occipital nerve, greater and lesser. If this fails, maybe go deeper. So what are the difference and diagnosis in the patient having an occipital headache? Is either the patient having the pain originally from muscle or from the upper cervical facet, and in the rare condition, in the neurosurgery condition, we call tonsillar herniation. Tonsillar herniation will actually cause compression of the upper cervical nerve, which it can cause the patient having occipital nerve. This needs surgery. If you delay or just neglect this condition, he may develop a syringomyelia and cause atrophy of the hand muscle. So carpal tunnel is a median nerve impingement at the retinaculi, tunnel's carpal ligament. So you can do a Phelan test. Patient will complain of some tingling or some numbness over the thumb or tinal sign. And this is another differential diagnosis. Patient can develop a thoracic outlet syndrome or the cervical nerve root impingement. For cervical nerve root impingement, you can do a Sperling test. Not very much high in the sensitivity, but if you elicit the positive result, means there's a nerve root impingement. Absent sign is more of vascular, but sometimes can cause neurogenic. But diagnosis of thoracic outlet syndrome sometimes can be very tricky. So this is a neuralgia parasitica. It's an impingement of the lateral cutaneous nerve when you pass through the ligament, inguinal ligament. Patient will complain of lateral part of the thigh become pain, tingling, warm feeling, and you can do a simple block at the nerve, at the lateral cutaneous nerve of the thigh under ultrasound guided. You can block it, the patient may feel better. Sometimes you give some neuropathic pain medication, can also resolve it. Sometimes I give a lignocaine plaster, that also can solve the problem. So what other differential diagnosis people always miss with the lateral cutaneous nerve entrapment is a greater trochanteric pain syndrome. When you have patient like that, you ask the patient to have a single leg stance test, the patient will elicit the patient pain. Or sacroiliac joint pain. Then you can actually do a Faber test or the sacral joint distraction test. Then you can tell whether it's pain or not. You can always ask the patient in a prone position, press on the sacroiliac joint. That can cause tenderness, also can elicit the pain. And lastly is the lumbar facet pain syndrome. Lumbar facet pain syndrome, patient complaining when he turns his body on the bed, feel the pain. So pudendal nerve entrapment is not common, but is always misdiagnosed. Some patients presented at the perineal pain, burning, tingling, sharp, electrical light, and a lot of time patient having some dysuria. And this patient will be subjected for multiple urinary tests, but ultimately is clear antibiotic is started, and then patient come back with pain, never resolve, and then another course of antibiotic. Basically, this is a pudendal nerve entrapment, which is the pain in the groin area. That is a picture of the lady and the man. The man in the testicular skin, sometimes in the penis area, also presented with dysuria. This one can easily use the ultrasound to block the nerve. Facial pain. Facial pain is 38.7 per 100,000 person year, and trigeminal neuralgia considered as one of the commonest facial pain. Another condition we call persistent idiopathic facial pain is very rare, but once happen, it's not easy to treat because you can't identify the pain generator. So orofacial pain can come from dental, TMJ, masticatory muscle, the chewing muscle, myofascial pain, and then you can come from the ENT, and neurovascular orofacial pain, like your trigeminal autonomic neuralgia, and neuropathic facial pain like trigeminal glossopharyngeal neuralgia, and of course secondary cause tumor, vascular. And this is the last one, is a persistent idiopathic facial pain, which is actually patient having a facial pain, but not according to the trigeminal territory, and sometimes can cross to the opposite side. So facial pain, broadly, we can understand by either it's a neuropathic facial pain, trigeminal pain, or atypical facial pain. So in a trigeminal pain, we have primary and secondary. Secondary is due to tumor, herpes, zoster, like post-herpetic neuralgia, traumatic, iatrogenic, and central cause. Iatrogenic sometimes can happen to a patient go for aesthetic procedure. He may injure the cutaneous nerve, and patient persistently have one area of painful area. So we need to rule out that. Sometimes nowadays, young lady, they go for all this aesthetic procedure. They rarely tell the doctors. I got a few patients, we go ahead with some procedure and surgery, ultimately fail. Then only they tell us that it's because of some injection to the skin. And also the dental procedure, like root treatment, can also cause painful condition similar to trigeminal neuralgia. And trigeminal neuralgia can be divided into idiopathic and classical. The idiopathic and classical, different by the idiopathic, we have a blood vessel, and the idiopathic have no blood vessel in the root entry zone, but classical we have the conflict of the blood vessel with the nerve. This is the picture. If the patient show this picture to the patient have this expression, a lot of times the trigeminal neuralgia. So trigeminal neuralgia primary, classical or idiopathic, the first investigation we do is MRI 3D CISS, is to identify the conflicting blood vessel to the nerve root. And then we can start with medical treatment first. Usually very effective initially is carbamazepine is the most effective medicine. If the patient responding to carbamazepine, almost always is a trigeminal pain. However, some patients can develop a severe allergic reaction. So we can do a HLA-B1502 genetic test to test whether the patient is prone to have an allergic reaction or not. But seldom people do. People start straight away. But always advise the patient, if develop any blister, go to hospital straight away, stop the medication. It can develop into the herpes zoster syndrome. Not herpes zoster, sorry. What we call it, run out of my mind, is actually a skin allergic reaction. Steven Johnson. The most important thing is a lot of people scared of Steven Johnson reaction, so they don't start carbamazepine. They start Lyrica and gabapentin, and seldom effective, very seldom effective. Carbamazepine is still the most effective medication. So what is next if the medicine fail? So we have a nerve destruction procedure and nerve protection procedure. Nerve destruction procedure is an intervention procedure when we use radio frequency and also balloon compression, with the objective of to partially destroy the nerve so that the nerve is not so sensitive to pain, but the price to pay is numbness. Patient may develop numbness over the area of the face. Some numbness is pleasant, not too bad. Some numbness is not pleasant. And another one of the nerve destruction procedure is radiosurgery. We use the radiation dose of 80 grays. For tumor, we only use about 20 to 24, but for this trigeminal neuralgia, we use 80 grays. That means 2 to 3 times higher than no tumor tissue. we call gamma knife, is precise, but however, this is nerve destruction. Some of them may develop numbness, and if the nerve recovered, the patient pain will come back again. And nerve protection is microvascular decompression to push away the blood vessel who compress on the nerve. For idiopathic, we can sometimes do a nerve destruction, but we have to warn the patient that the outcome is not easily predicted. Sometimes we also do nerve protection procedure, but unlikely effective because there's no conflicting blood vessel. Ultimately, we do the sphenopalatine ganglion radio frequency. So this is the procedure of the intervention, putting a needle 1 inch or 2 centimeters away from your angle of the mouth, and then push to your foramen or ovale under the image guidance until you reach the trigeminal ganglion. It's a very painful procedure. So a lot of time we get the NS colleague to deeply sedate the patient when the needle is put. But for this radio frequency, we can precisely choose you want the V2 division or V3 division. I don't agree with doing the V1 division because it can cause the cornea anesthesia and cause eye injury in future. So when V1 is affected, we use balloon. Balloon are more protecting to V1 cornea anesthesia. But this balloon compression is under GA. This is gamma knife machine. Then we can precisely targeting the nerve and then we give a radiation. However, this is not instantly relieve the pain. It may take few days, few weeks for the pain slowly coming down. However, whether it's all gone or not, very difficult to predict. All this nerve destruction, ultimately, we still continue some medication. This is an MED procedure. That means we actually put some Teflon to separate the nerve, to separate the artery from the nerve, so that the nerve is not being pushed by the artery, so that the pain can be resolved. So we are now opening the RNA membrane and fasten the thing. Then you can see there's a superior petrosal vein. Then we have to, sometimes we need to sacrifice superior petrosal vein, the white color. This is the trigeminal nerve, and the blood vessel is behind the trigeminal nerve. And then we have to slowly dissect. Cannot injure the trigeminal nerve, otherwise patient will have some pain and numb. The artery also shouldn't be aroused, otherwise patient may have a stroke. So after that, you can see, you can put the Teflon in between so that the artery are not directly in contact with the nerve, so that the pain will be relieved. And this procedure, I like it very much because it's giving you an instant pain relief after the surgery. Medicine can stop 100%. So, talking about the trigeminal neuralgia, we have some other condition similar to trigeminal neuralgia. We call it a hyperactive cranial nerve dysfunction syndrome. Another painful condition is called glossopharyngeal neuralgia. Patient having a throat pain. This throat pain patient a lot of time refer to ENT. They look into the throat, check the tonsil. A lot of time are normal. Some of them even go for tonsillectomy. The pain persists because the pathophysiology is the glossopharyngeal neuralgia in the CP angle in the brain, like the trigeminal neuralgia. Patient having very difficult to swallow. It's different from trigeminal neuralgia. Trigeminal neuralgia is actually chewing causing pain, but glossopharyngeal is swallow causing pain. Geniculate neuralgia is even more rare. So geniculate neuralgia is a patient complaining of the pain inside the ear, like you using a knife straight away stab the ear. You know? So some patients complain like that. A lot of time refer to ENT, but ENT can't find anything. Tympanic membrane is okay, putting a scope there, everything is okay. Don't know why this patient having the pain. A lot of time this is geniculate neuralgia. Of course, hemifacial spasm is not a painful condition, but this happens in the same condition we call hyperactive cranial nerve dysfunction. Other rare conditions like your torticollis, like your hemilingual spasm and vertigo and tinnitus. Okay, this is a post-traumatic facial pain. This patient having a traumatic facial injury, plating all done, and then having a very severe pain over the face. You can see it's actually a bit red and swollen. This patient seeking a lot of consultation, but nobody know what to do. But a lot of people say that why not you remove the plate? But it's useless to remove the plate. It's not the plate causing the pain. It's an injury to the cutaneous nerve causing the pain. So this patient, we do a sphenopalatine ganglion block. So we just put a needle there to this small area, the ganglion there, and then you block it. And then you can do a radio frequency to solve the pain. So spinal pain. Spinal pain means neck, back, and lumbar pain. We have so many other conditions. We can have a muscle pain, we can have a joint pain like your allantooccipital, allantoaxial facet, sacroiliac joint pain, disc pain, discogenic pain, herniated disc, bone pain, compression fracture, metastatic bone disease, nerve pain, radicular pain. And other than that, like Arnold Chiari, I've already explained, cervicogenic headache is upper cervical facet pain, greater and lesser hospital neuralgia, carpal tunnel can sometimes misleading. Patient may have a carpal tunnel at the same time may have a C7 compression. C6, C7 compression we call double crush syndrome. Thoracic outlets syndrome already explained. Neuralgia parasitica already explained. Coccydynia is a pain at the tailbone. And other special condition like post-spinal surgery pain syndrome. Last time we called failed back surgery syndrome and whiplash injury. So this is all the procedure. Very, very busy slide to show all the procedure possible to treat spinal pain. And this is a cervical facet pain. You can see the medial branch there. You need to burn 2 branches for 1 joint. And this is what we do. You can do the ultrasound guided. You can do eye guided. Put the needle there at the middle branch. You use a radio frequency. You can actually burn it. You can even use ultrasound to locate the medial branch, and then you can use this to block it with the local anesthesia. Analgesic solution like your ropivacaine and your lignocaine. Cervical discogenic pain, sometimes very difficult to diagnose because the pain is referred to some part of the body, not really in the neck. So we can do a cervical epidural block interlaminar. Somebody do a laser cervical discectomy, all these things. But study have done is not really a strong evidence to show benefit. So the cervical epidural block is still the best to relieve the discogenic pain of the cervical region. So low back pain, what we have. Same thing here, this related pain, lumbar facet, radicular pain, facet pain, myofascial pain, SI joint, coccydynia. And lumbar radicular pain can due to the spondylosis, radiculopathy, disc herniation, and failed back surgery syndrome. So the lumbar facet pain, same thing, 1 facet, 2 nerve need to burn. And this is the lumbar facet pain. We have to identify where is the median nerve and put a needle there and give a RF and give an epidural, lumbar epidural to relieve the pain. But epidural is effective to relieve the pain. But if the epidural need to give more frequent than 3 monthly, that means I think we have to look further for more invasive procedure for pain relief. There are so many ways. You go transforaminal, you go interlaminar, you go caudal. Caudal means you push through the sacral caudal foramen. So the lumbar radicular pain, you actually give some radio frequency to the lumbar nerve root so that the pain can be reduced for a certain duration. So this is the lumbar discogenic pain. Lumbar discogenic pain, the patient come to your clinic, you see the gesture of the way he sit, always sit very straight because bending down causes the pain. And the lumbar discogenic pain patient will complain he cannot sit for long. He sit, he need to stand up. He sit, need to stand up because why? When you're sitting, you're actually flexing your lumbar spine. When you're flexing your lumbar spine, it causes more stress to the disc, and this causes pain. So it's called lumbar discogenic pain. A lot of young people now come to see me for lumbar discogenic pain because they sit too long. Last time when I was young, I was beaten until to sit down. Now, I think you beat the young people, they don't even want to stand up. So that is the issue. So lumbar discogenic pain, the evidence show by acuplasty is the best treatment. Somebody do laser, somebody do nucleoplasty. But acuplasty is according to the pathophysiology of posterior disc pain, posterior disc pain. So this sacroiliac joint pain happen in old lady, they complain of when you climbing up staircase or standing up from sitting position. So you need to ablate the sacral nerve to the joint. So coccydynia pain when the patient fall down, especially nowadays young people like to go for all this skiing, this and that. Skating, ice skating, when fall down, he will actually cause pain at the tailbone. Then we can put a needle there in between the sacrum and the coccyx junction. Give a contrast, and then we can actually give some block. So piriformis syndrome, you can do a fair test. Means you flex the knee and internally rotate the knee. When you see the pain or sciatica, that means the piriformis syndrome. Somebody use a blind method to block the piriformis muscle. Somebody use the ultrasound. So this is the percutaneous epidural neuroplasty happen. If there's a scarring at the epidural space, you can put the wire there and push the wire, give some high-lase enzyme to actually lyse the scarring, and then to release the adhesion of the nerve root. Now, endoscope spine surgery is no more new, but it's not popular in Malaysia as yet, but I think it's getting more popular now. There are 3 types of endoscope, but the full endoscope is only 1 portal. So this is an example of the surgery to the patient having a disc at the same time is a spinal stenosis. Just open up a small hole, maybe about less than 1 centimeter. Then you can do all the job. Last time we need to remove a lot of normal anatomy to reach the pathology, so we need to putting in all the instrumentation. Nowadays, we no need to remove so much of the normal anatomy, so basically you don't need so much of instrumentation. So this is a picture to show. Beside that is my thumb, and this is an incision. It's so small incision enough to do bilateral decompression and discectomy already. So you can see the lamina. After you see the lamina, drill away part of the lamina of one side, not even whole lamina, only part of the lamina of one side. After you remove the lamina, we call laminotomy because it's not even hemilaminectomy. So you will see the ligamentum flavum. After you see a ligamentum flavum, you try to remove the ligamentum flavum, which a lot of time is actually causing spinal stenosis in old age. Faster. Okay, this is the taking out part of the lamina. You can see the yellow soft tissue below my cavison. From here, then you can see this is the ligamentum flavum. After the ligamentum flavum, you should see some epidural fat. After the epidural fat being removed or being pulled out a bit, then you can see the thecal sac. The thecal sac is here. Then you can remove both sides. So the thecal sac, when you see the thecal sac, below that is your nerve root. Okay, after you see the thecal sac at the nerve root, then you have to use a smaller tube to push in and then retract the nerve root and then go to the disc space. Now this is the disc space. Change the tube smaller, so you go to the smaller tube and then you push away, and then you push in the tube, and then you retract the nerve root, and then go to take out the disc. This is the disc to take out. The disc is coming out. So this is the way we do endoscope spine nowadays. Patient can come in, can actually do the surgery today, go home tomorrow, not even need any post-op analgesic, not even need ECM. Patient don't feel any pain because there's no muscle dissection. So this is out. Then you check again, if everything is out, okay, it's finished. So this is a small wound. You can see there's a pump there. This is transforaminal discectomy through the side of the body. This one don't even need to drill the bone. No bone is drilled. You go through the foramen, cabin triangle. So what is the indication for endoscope spine? This herniation, stenosis, spondylolisthesis. Nowadays, we can even use scope to do fusion, removal of certain pathology, things like epidural abscess, epidural hematoma. Advantage, reducing collateral damage, preservation of the facet joint. The facet joint are untouched. Stability is maintained. View is magnified by the endoscope. Low risk of infection because continuously the irrigation of fluid during the procedure. Cost effectiveness, patients stay in hospital shorter duration, and then low risk of surgery-related morbidity, basically post-op pain, and reduce the need for instrumentation and fusion. What is failback surgery syndrome? Failback surgery syndrome can be due to surgery by majority because of the scarring and adhesion of the nerve to the surrounding tissue. It's very common, even up to 50% of the successful spinal surgery still have some residual pain, sometimes even worse pain. So this is the procedure we do for this failback surgery syndrome. Is a spinal cord stimulation. Two-phase spinal stimulation. Two-phase, actually, it's just like your pacemaker. Actually, he continues to stimulate the dorsal column to block the pain sensation to be sending up to the brain. You can use the percutaneous method. This is a percutaneous method you see in the video. The lead is then steered according to the level we desire, and then to the area that actually to stop the pain. They call spinal cord mapping. You can have a surgical pedal lead also is an open surgery procedure. After the trial phase, then only we go for the permanent implant phase. Chronic post-surgery pain. Chronic post-surgery pain is quite common. Even up to 50% of the patient undergo any surgery can have pain. Cesarean section pain, inguinal hernia repair pain, appendectomy pain. A lot of surgery, as long as they cut the skin, there's a chance they will cut the cutaneous nerve. And some of the patient can develop persistent post-surgery pain. And this is the chart to show that the percentage of post-surgery pain. Abdominal surgery can go up to 20%. Amputation can go up to 85%. Cesarean section can also go up to almost half, 55%. Cholecystectomy, 50%. So you see, it's quite high post-surgery pain. Just because of the wound heal well, nobody believes patients suffering in pain. Because I see so many patients come to see me, they are so angry, frustrated. They come to see me, their face also not smiling. They thought another doctor also tell them to go home. There's one patient with the hernia repair pain. So I just blocked the iliohypogastric, ilioinguinal nerve. The pain just disappeared. I got one cesarean section patient from Africa, go everywhere seeking for help. Coming to Malaysia, upper scope, lower scope, all done, all normal, hysteroscope, everything normal. Ultimately, they don't know what is happening to the patient. Maybe need to refer to psychiatrist, you know. He come to see me, I just ask the history. It's all history. Pain management is all history taking. So I just ask the patient, where's the pain? How's the pain? Where's the skin? The pain area, do you feel any different? He said, oh, my pain area is actually a bit numb. So I know it's a neuropathic pain. You just tap the area of painful, then you elicit the pain. Then I just block the, what do you call it? Ilioinguinal or iliohypogastric, the pain also go away. So a lot of surgery pain is because of cutaneous nerve pain. Even people do a thoracotomy also can have pain. Then we need to actually look for it. Even mastectomy also can have pain. Or every surgery can have pain. Even craniotomy can have pain. So depending on the craniotomy, which nerve is there, then you block the nerve. Like a tibial nerve, you can block the auricular temporal nerve. Like hospital surgery, then you can need to block the lesser or greater occipital nerve. Like your mastectomy, you need to block the long thoracic nerve. Like your other clavicle fracture patient, you can block the lateral pectoral nerve or medial pectoral nerve. Like your rib fracture, you can block the lateral cutaneous nerve, intercostal nerve. So this patient actually, this type of nerve is safe to block in the clinic setting. So this is all the cutaneous nerve of the abdominal surgery. Depending on which abdominal surgery, you can actually block in your clinical setting by ultrasound guided. So chronic visceral pain. Chronic visceral pain means patient having a chronic abdominal pain, chronic pelvic pain, even chronic chest pain, chronic angina with normal the coronary artery pathology, all normal, all this chronic visceral pain. And then for the hand pain with the complex regional pain syndrome, you can even do a stellate ganglion block or radio frequency. For the abdominal pain, chronic pancreatitis, we can block the the splenic nerve. Even celiac plexus you can block. And there's splenic nerve, but this splenic nerve a bit difficult. You need to do under eye guidance. And then celiac plexus, and then hypogastric for pelvic pain. I see patients with all this neuralgic pain, you know, endometriosis. All these things you can block the hypogastric nerve. And this is ganglion impact for your crocodilia pain, chronic limb pain syndrome. What is the chronic limb pain syndrome? Like chronic arthritis, your knee pain, chronic knee pain, post-traumatic like your brachial plexus avulsion pain, and then chronic post-surgical pain like total knee replacement pain, chronic complex regional pain syndrome like patient having injury to the hand or to the leg, but the patient healed, the wound all healed, fracture all healed, or sometimes not even any obvious injury to the limb, but the patient developed limb pain, redness, sweating, swollen, sometimes bluish. This is a complex regional pain syndrome. Chronic ischemic limb pain. Nowadays, we can even treat chronic ischemic limb pain by blocking the lumbar sympathetic chain. Raynaud syndrome to block the stellate ganglion. Phantom limb pain a bit tough. Sometimes need to go into the brain and stimulate part of the brain using deep brain stimulation. This is a complex regional pain syndrome. You can see one hand is red, swollen. Freeze is also less. And this is the hand. And the other leg, you can see if you don't treat them early, they may develop, ultimately become dysfunctional and non-functional. So for the hand, you can block the stellate ganglion. For the leg, you can block the lumbar sympathetic chain. But ultimately, at the current day, they suggest that spinal stimulation is the best treatment for all this complex regional pain syndrome. Shoulder pain, targeting the suprascapular nerve. Knee pain, targeting the nerve, the genicular nerve, but you have to be very careful. Don't do at the fibula level, because fibula there is a peroneal nerve. If you do the lower near to the fibula, you can injure the peroneal nerve. Patient may have a foot drop. So lastly, my last slide. Luckily, my time is not up yet. Not all pain can be removed, but no pain should be ignored. Any people can actually finish. Yeah. Anybody want to get my opinion or what, can contact me or email to me. Thank you.
Okay, thank you, Tanjan. You stop sharing your slide. You're speaking at 1.5 times of your normal speed of speaking. You should split to two lectures other than one at one go. So for those who came in late, I want you to remind all of us what is the red flag and the yellow flag symptom that we have to be careful of.
I'm stuck with the stop sharing. Okay. Yeah. All right. Yeah. Dr. Wong, again, what is the question?
Yeah. For those who come in late, can you tell us what is a red flag and a yellow flag symptom that we have to be aware of?
The red flag symptoms are most of the pathological issue. I have few patients come to see me like back pain. I got one patient come to see me with a chest pain. Patient actually underwent a lot of stress test, angiogram to the heart, CT scan, MRI, everything they do for the heart, but ultimately it's all negative. This patient having a pain at the thoracic level, and the nerve pain usually happen at night. They normally complain at night time, they feel more painful. So this most of the time is a night pain, is most of the time is a nerve pain, a lot of time got tumor, especially the night pain of the back, night time of the neck, night time of the back is all because of the tumor. That patient actually initially complained of chest pain, investigate for cardiac causes, ultimately is having a tumor in the T4 tumor. After surgery, unfortunately, it's a malignant tumor. It's a sarcoma, but until now, it's still quite well controlled. So sometimes pain, this is what we call red flag. We don't want to miss any possible life-threatening or limb-threatening condition. If you're in doubt, we can always do some imaging to rule out the red flag condition.
Okay. How about yellow flag?
Yellow flag is more of emotional. Emotional means a lot of time patient coming in, walking also one kind, talking to me also one kind of expression. Sometimes I dig into their social history, then only I realize some of them, the husband actually having a second wife, and then they have few kids, and the financial is stressful. After talking for 1 hour, the patient pain also reduced. So a lot of time, this is what we call yellow flag. Yellow flag can contribute to the pain condition. So sometimes you have to talk to the family member. Sometimes the family member also fed up, not supporting the patient, and then thinking the patient are creating trouble. The whole family is stressed because it's pain. But doctor always said, your wound is okay, but there's no injury. Your skin is okay, but not inflamed. So you sometimes have to educate them. Chronic pain doesn't mean you can see all the sign of inflammation. And then the husband and the family have to support in the correct way. Shouldn't actually encourage pain behavior. That means that when the patient walk in a very awkward way to attract attention, some patients want to attract attention, but the pain always start with pain first. So always I advise a family member, you don't encourage them have a pain behavior, but you got to support them to face the pain. Don't say that, oh, patient have some crooked away, oh, please sit down, maybe you have so much of pain, all these things. You only encourage them to do more of this kind of pain behavior.
Okay, in my practice, sometimes we see patients with referred pain. And one of the examples that I have is that they come in to see me for chest or abdominal pain. But no, actually they come in for headache. So when they come in with headache, but they have symptoms of gastric bloating. So I'm not treating the headache, I'm just giving them a gastric medicine, a PPI, and the headache disappear. So how do you explain this type of referred pain? Instead of treating all the painkiller for the headache, but treating the root of the problem is more important.
Correct.
So, can you comment on this?
Sometimes the stress can cause them a lot of other pain, which is not obvious. And having said that, on the other hand, also when you treat one pain, the one pain you treat may disappear, but other pain which is not obvious become obvious because our brain only interpret the most painful part.
Okay. And you also mentioned that some of these conditions like carpal tunnel syndrome, if you don't treat it properly, the nerve may become fibrous and atrophy. So that means that all patients with carpal tunnel syndrome should be sent for surgery?
No. Actually, carpal tunnel syndrome, you can go for some physiotherapy first. Of course, fat patient, you can reduce the body weight first. A lot of disease come from obesity. Another thing is for pregnant lady, don't touch them because after they deliver the baby, all the carpal tunnel pain all disappeared one.
Okay. Okay, another thing that I want to ask you is that you said some of this condition you block the nerve. But when you block the nerve, the signal that protects us by giving us pain will disappear. So is it counterintuitive and harmful to block the nerve?
Actually, to block the nerve are not actually to make the pain sensation totally go away. Just like, okay, for example, the patient having a cesarean section, having this pain due to the cesarean section scar. So you block the ilioinguinal, iliohypogastric. Okay, the analgesic agent that we use only lasts a few hours, but most of the time we add on the steroid to reduce the local inflammation. It doesn't make the nerve sensation totally go away.
So it's a short-term solution then, it's not a long-term solution?
You can say it's a short-term solution, but sometimes the pain cycle is because of the initial pain. You break the cycle, a lot of time the patient forget the pain, then the pain would not come back because sometimes the stress, the frustration increase the pain sensation. This is what called central and peripheral sensitization.
Okay. So from what you just answered, it seems like our mental contribution to this pain is very high. So is it fair to say that some of this alternative thing like yoga or stress reduction may help with this kind of pain?
Oh yeah, totally yes. Because a lot of time we need to advise patients to go from some yoga, some meditation, this and that. Because just like my last slide, not all pain can be removed. So to a certain extent, we can make the patient to live better with the pain they have, which cannot be removed easily. Some nerve pain is already injured, is injured. It's destroyed. So that means we have to use other way to make the patient live with it.
Okay. There's a question from the floor from Dr. Swaran Singh Kundan. He asked how many % of the population really comes with red flag symptom compared with yellow flag symptoms?
Yellow flag is most of the time higher than the red flag. If you ask me the percentage offhand, I can't give the percentage. But the most important thing is the red flag condition is a lot of time worsening. And then that means over time they get worse. And then if they add on some other symptoms like your motor deficit, then you have to be very careful.
Okay. So what do you think of this acupuncture as a way to relieve pain? It seems to work in some conditions. So what condition can be helped by acupuncture?
A lot of patients ask me the same question because I have no knowledge about the acupuncture, but acupuncture did show there is some pain relief effect. Until today, a lot of people thinking maybe partly is because of the placebo. Because any puncture or any needling or any massage actually to our muscle will create our body to produce endorphin. So that endorphin somehow will reduce our pain. And that endorphin will be digested by our own body. That's why people who go massage today, they feel better. But after 1 or 2 days, they want to go massage again. It's not very long lasting.
Okay. And what do you think of supplements like vitamin B12, methylcobalt, folic acid, and magnesium in terms of this neuropathic pain?
Some of the deficit in all these minerals can cause pain, but I can't really tell how much to take is enough. Methylcobalt and vitamin B12 is for nerve recovery. But frankly speaking, if the nerve is totally avulsed, I don't think the medicine is helpful.
Okay. So you have shown some of this operation on your presentation. So I wanted to ask you, what is the side effect and the cost of doing some of this operation? It seems to be it's a very minimal invasive. So is it high complication rate or low complication, and the cost of doing some of this operation that you just shown to us?
Okay, I think minimal invasive is a marketing term more than medical term, because minimal invasive is not minimal risk, because the area of interest is still the same, the depth of the surgery is still the same, the risk of the surgery is still the same, but the minimal invasive give a lot of public the impression is lesser risk, never a lesser risk. Because if you take the consent for minimal invasive, you always add on KIV, open surgery. If an open surgery can save your minimal invasive, by logic, open surgery should be safer, because you can save minimal invasive. But minimal invasive, one thing good is, if your skill is already reached the level as good as the open, but the destruction of the surgery to the surrounding tissue is minimum, patient pain is minimum. The only advantage of a minimal invasive surgery is the recovery period is fast. The recovery period, if you think again, any surgery, the recovery period is all because of the muscle and the cutaneous. Yeah, the inside is all sutured up already.
Okay. Okay, there's a very good question from the floor from Dr. Wan Non Ainin. She asked, how can we manage painful diabetic neuropathy in the primary care settings, despite intensive glycemic control, risk factor management, and also symptomatic pain management, but the patient is still having the pain? Are you able to help?
Okay. For diabetic neuropathy, it's not simple because it's a generalized disease. Of course, initially the sugar control is a main treatment. If come to the pain, then you have to think about neuropathic pain medication. Neuropathic pain medication, a lot of people will suggest about antidepressant one, the duloxetine, Cymbalta. If that is not helpful, somebody suggests to do a lumbar sympathetic block and see. The lumbar sympathetic block may reduce the suffering. And yet, if the painful diabetic is only one part, you can always think about using the lignopad plaster, which is lignocaine plaster, to the painful area. Sometimes it's helpful.
Okay, another question from Dr. Pek Gan Cheng. She asked, in pregnant patient with unbearable paresthesia pain from carpal tunnel syndrome, what will be the appropriate measurement other than physio? Pregnant patient with a lot of carpal tunnel syndrome pain, any other treatment apart from physio?
Okay, because in the pregnant lady, a lot of medication are not advisable unless it's unavoidable. So if you really want to treat the patient, sometimes we just locally treat the patient. Means we can give a block or the steroid to the carpal tunnel area to relieve the pain. Usually steroid can give a pain free for more than about few months. enough already, because pregnant patient to have a carpal tunnel normally in the almost end of the pregnancy. I got one patient with the patient having a liver transplant. He donated part of the liver to the father. And then he got so much of pain at the abdominal wall there. He come to see me. I also scratch my head because you cannot start a lot of medication. And then you cannot use II to locate the spine to give a nerve root block. Ultimately, no choice. I have to use the paravertebral block by ultrasound guided. As long as you don't use II, a lot of time is quite safe. Local steroid and local analgesic agent, according to the patient, tell me the ONG doctor say no problem.
Okay, I think we have spent more than 1 hour with you already. And maybe you can give us some take-home message for general practitioner out there. What are the things that they have to watch out for? And what are the conditions that can be treated by you rather than treating them conservatively?
I always tell take home message first. You have to differentiate the patient is having a nociceptive or neuropathic, because the medication is very much different. Having said that, some of the nociceptive pain, like your NSAID, like your COX-2 inhibitor, are not advisable to take very long-term and regular. So ultrasound maybe is a preferable choice for old age. This is the first take-home message. Second is, if you suspect the pain is progressively worsening, then you need to at least rule out the red flag condition. If you fail the medication treatment, may need to do some intervention. Some intervention that can be done under GP level, I believe, all the myofascial pain, finger point infection, peripheral nerve, under ultrasound should be quite safe. Anything mixed nerve, you have to be very careful. Like carpal tunnel, if you give a block, if you inject the nerve, the patient cannot move the thumb, Some cutaneous nerve, like your iliohypogastric, like your ilioinguinal, that is okay. It's a cutaneous sensory nerve. Not too bad. But any mixed nerve with the nerve and the motor, sensory and motor mixed nerve, you have to be very careful. You inject the nerve means you actually take away part of the motor function. But no pain, you should delay treatment, because it can cause central sensitization and peripheral sensitization, and you will reach the level that's very difficult to treat, even with any way. Because psychologically, stress is too much and then difficult to reverse.
Okay, thank you, Dr. To. And I think we gained a lot from you. Maybe I invite you to come back again and you can speak in a normal speed. So I think with that, we thank Dr. To with his knowledge, and hopefully we can meet up again. And the next month, we're going to have a session with a chiropractor. So the chiropractor will explain to us their principles and also some of the conditions that they can treat. And a lot of time they are dealing with all this musculoskeletal pain and also structural problem. So we can see the difference in their approach. Okay, with that, thank you, Dr. To, and thank you all of you for listening.